Chapter 14, PET CT and SPECT CT hybrid scanners. We know that CT can provide in-depth anatomic detail of a patient that is extremely beneficial to the patient's diagnosis, but what does positive emission tomography, or PET, and single photon emission computed tomography, SPECT, provide? They actually provide functional information regarding the patient. However, SPECT and PET do not show anatomic detail very well, and this is why it is helpful to correlate between CT images as well as PET and SPECT images in order to make a diagnosis. We will begin by discussing the principles of PET imaging. Radioactive atoms are used, and these are atoms with an unstable nucleus. It either has too many protons or too many neutrons. Atoms may seek to become more stable by undergoing a nuclear transmission with the emission of a particle such as a gamma ray or an alpha or beta particle. A positron is a positively charged beta particle, and it has the same mass as an electron. One advantage to PET imaging over other nuclear imaging techniques is that many of the radioactive isotopes of elements of biological interest, such as carbon, oxygen, and nitrogen, are positron emitters, which means that the pharmaceuticals using these isotopes can be imaged using a PET scanner. Also, radioactive fluorine can be very useful as it can often be chemically substituted for a hydrogen atom or a hydroxyl group. This means that radiopharmaceuticals such as O-labeled water, N-labeled ammonia, C-labeled methionine, C-raclopride, or FDG can be produced. Other radionuclides of interest in PET imaging include rubidium-82, which is used for cardiac imaging, and gallium-68 for oncology imaging. So, in PET imaging, annihilation coincidence detections occur. In this kind of detection, the atom transforms by emitting a positron. The positron then travels several millimeters into the tissue and loses its kinetic energy, and it then combines with a neighboring electron. Then the positronium forms from this combination, and a positronium is a positron-electron pair. The positronium annihilates after a very short time, and it actually converts its mass into two photons that are emitted back to back, almost exactly in opposite directions. The energy of the two photons is determined by using Einstein's equation, which is E equals mc squared. Coincidence detection occurs when photons interact with detectors on the opposite side of the PET scanner, and they are detected within a short time window. And then the annihilation event can be assumed to have occurred along the line that connects the two detectors. And this is referred to as the line of response, or the LOR. The spatial resolution of a PET scanner is determined by the size of the radiation detectors used in the scanner. So if the scanner uses 4 millimeter detectors, like most modern PET scanners do, the spatial resolution can be assumed to be about 4 millimeters, or perhaps slightly more. Two small detectors on either side of the patient wouldn't collect many photons, so placement of a large number of small detectors around the patient is necessary to acquire high-resolution PET data in a reasonable amount of time. Take a look at figure 14.2 to see an example of a ring of detectors commonly found in modern PET scanners. A single detector on one side of the patient is in coincidence with several hundred detectors on the opposite side. There can even be as many as 500 to 700 small detectors in a single ring. Annihilation coincidence detections aren't the only kind of coincidence detection events. There is also the true coincidence detection, which occurs when both annihilation photons exit the patient without incident and are detected in coincidence. Take a look at figure 14.4 in your book to see an example of this. But sometimes one of the photons undergoes a Compton scattering prior to exiting the patient. The line of response associated with this coincidence detection may not pass through the annihilation event, and so it doesn't accurately localize the event, and this is referred to as scatter coincidence detection. Random or accidental coincidence detection occurs when two photons are detected in coincidence, and the line of response doesn't accurately localize either of the annihilation events. This can lead to background activity that reduces image contrast, and this can be minimized by reducing the coincidence timing window or reducing the detector count rates. The crystals used in the production of PET scanner detectors are scintillators. Photons interact in the crystal, resulting in the emission of light, which is collected by an array of photomultiplier tubes. Sodium iodine is used in gamma cameras, and they emit the most light per photon, yielding the best energy resolution. But the lower density and the lower effective Z number, or the average amount of photons per atom, leads to lower detection efficiency. This means that a smaller fraction of photons strike the detector and are detected. Bismuth germanate has both a higher density and effective atomic number, so it has a higher detection efficiency. However, both the sodium iodine and the bismuth germanate emit their scintillation light rather slowly. This requires a longer coincidence timing window. Lutetium oxyorthosilicate, that's a mouthful, and gadolinium oxyorthosilicate have reasonably high detection efficiencies and emit their light much more quickly. The ring diameter of most PET scanners is 70 to 100 centimeters, which means it takes about 3 nanoseconds for an annihilation photon to traverse the scanner. If the scanner's temporal resolution is fast enough, an individual might be able to determine the time difference between the detections of the two annihilation photons and tell where along the line of response the event occurred. This approach is referred to as the time of flight. This localization data can be used by the reconstruction algorithm and leads to a more accurate reconstruction of the PET data. Time of flight PET scanners reduce noise in the images, and they are related to the size of the patient. The larger the patient, the greater the impact of the time of flight. All of the major vendors that market PET CT scanners also provide time of flight as an option. At this point in time, all commercial whole body scanners are hybrid scanners, usually being PET CT scanners, but there are some PET MR scanners out there. The CT portion of the hybrid PET scanners, of the hybrid PET CT scanners, use multi-detector CT technology, usually incorporating 32 slices or more. The PET CT scanners are 2 separate machines, and they are in close proximity with a single bed that moves the patient between the 2 machines. And the PET and CT data are acquired sequentially. So the CT scout scan is done first, then the CT images are taken, and then the PET images. And a typical whole body PET CT scan takes about 20 to 30 minutes. We will move on now to the principles of SPECT imaging. The advantage of SPECT over PET is that SPECT doesn't require the radiopharmaceutical to be a positron emitter. And this means that all of the radiopharmaceuticals regularly used in nuke med can also be used with SPECT. SPECT has been used to routinely image the brain, skeleton, heart, and kidneys, and has also been used for tumor imaging. The disadvantage, though, to SPECT is that it has a relatively low sensitivity as compared to PET because it needs to use absorptive collimation, and this makes it actually almost 100 times less sensitive than PET. In a typical SPECT acquisition, the patient is administered the radiopharmaceutical. Usually this is done by IV. And after an uptake period, sometimes it's as short as several minutes and as long as several days, the patient is then placed on the imaging table and moved in place for imaging. A large number of projection images are taken, this can be from tens to hundreds, and are then reconstructed into a tomographic data set consisting of a series of transverse slices through the patient, and this is done very similarly to that used in PET or CT. SPECT scans usually have extended acquisition times, which make it not commonly used for dynamic studies due to the motion. The most common instrumentation used for SPECT is the rotating gamma camera. The most current SPECT gamma camera systems consist of two rectangular, large field of view camera heads mounted opposite each other on a rotating gantry. The camera heads can be placed in a 90-degree configuration so that a complete set of projections over 180 degrees can be taken with a 90-degree rotation of the gantry. The gamma camera rotates around the patient, typically acquiring 60 to 100 projection images that are later reconstructed. And the camera heads can also move radially as close to the patient as possible to maintain high spatial resolution. Take a look at figure 14.8 in your book to see an example of a SPECT CT scanner. Attenuation correction. The probability of detecting a photon emitted from the center of an object is less than that for an event on the periphery of an object due to the fact that the photon is more likely to be absorbed or scattered if it has to travel through more material. If there are two features, each with exactly the same amount of activity, the one on the periphery will have a higher signal than the one at the center. To achieve uniform quantitative accuracy, the spatial variation and attenuation must be corrected. An effective approach to attenuation correction for PET or SPECT scanning is to use the data from a registered CT scan, which means the same size and in the same orientation and sliced along the same planes as the PET or SPECT scan. This registration can be achieved by taking both data sets with a hybrid scanner or by applying a software registration algorithm to the emission and CT data that were acquired on the separate machines. The major differences between attenuation data from CT and data needed for attenuation correction are that the photons used in CT have much lower energy than photons from PET or SPECT. The usual CT tube voltage ranges from 80 to 140 kVp, and this means that the mean energies are in the 35 to 50 keV range. And on PET scanners, or PET and SPECT scanners, they usually use 511 keV, and the energies are between 80 to 360 keV. Spatial resolution is another major difference. The CT spatial resolution is usually 1.0 millimeters. The PET spatial resolution is usually 6 to 8 millimeters, and the SPECT spatial resolution is 10 to 15 millimeters. So how do you take a PET CT scan? First, the patient arrives in the PET center and is injected with the PET radiopharmaceutical. The patient then has to wait in this room, usually while the radiopharmaceutical distributes throughout the body. The amount of waiting time depends on the biokinetics, which is the study of movements relating to organisms, associated with a particular tracer. Then the patient is taken to the scanner room and placed on the imaging table. The CT scout view is taken, and this can be used to position the study anatomically. The CT scan is then usually acquired first, just before the PET emission scan is taken. Some clinical examples of when PET CT imaging is used includes in oncology, usually for the lung. PET with FDG is a powerful imaging modality for use in initial diagnosis, staging, and follow-up of lung cancer. Most lung cancer nodules are FDG avid and generally are surrounded by tissue with relatively low FDG uptake. Oncology, as far as lymphoma goes, is another clinical example of where PET CT is used, and this also uses FDG. Epilepsy is another clinical example. This as well uses FDG, and it's been proven to be useful in the localization of epileptic seizures. PET CT is also useful in cardiac scanning, and this again uses FDG. The myocardium is variable in its affinity for FDG, but it can be made to be FDG avid. The patient is given a drink high in glucose followed by an insulin injection, and the FDG is then injected once the blood glucose levels return back to normal. This is often used in conjunction with a myocardial perfusion SPECT study. We will discuss a basic procedure for a SPECT CT scan, but certain aspects may vary from patient to patient. First, the patient comes to the nuke med department to be imaged, and depending on the specific procedure, the radiopharmaceutical might be injected, it could be inhaled, or it could even be ingested in advance of the patient's appointment time, or even after the exam has been started. The time between the administration of the radiopharmaceutical and the imaging could vary from seconds or to even days. The choice of how and when to introduce the tracer depends on tracer dynamics and the clinical objectives of the study at hand. The patient is then placed on the imaging table after waiting the appropriate amount of time for the uptake of the radiopharmaceutical. A scout CT image is taken, and based on this, the field of view is determined for the study. The CT study is acquired, followed by the SPECT study, and the CT and SPECT studies are reconstructed and registered to provide the fused image set for review by the nuke med physician or radiologist. The book discusses a number of clinical examples of SPECT CT studies, but I'm just going to review a few of them lightly here. It is used in musculoskeletal imaging, and this is often called a bone scan. It is used to diagnose and monitor certain bone pathologies. The radiopharmaceutical is injected into the patient, and it concentrates in the bone tissue according to the rate of turnover. The patients are usually scanned after 3 hours after the injection. It is also used for parathyroid imaging, for parathyroid tumor localization and surgical planning. And normally, a radiopharmaceutical such as TC-Sestamib is used. The neck is imaged about 2 hours and 20 minutes after the injection. Thyroid imaging is another clinical example of SPECT CT imaging. In thyroid imaging, radioiodine is used, and the iodine concentrates in the thyroid tissue. And the iodine uptake shows the thyroid as a high contrast on the SPECT camera. Myocardial perfusion imaging uses TC-Sestamib, and this type of study is actually the most commonly performed nuke med study, and it accounts for about 50% of radiopharmaceutical imaging procedures. These studies assess the blood flow or perfusion to the myocardium in the heart. These studies are often performed twice, once with the patient being administered TC-Sestamib at rest, and again with the patient undergoing stress. This is either done through exercise or the use of vasodilating drugs.